Hello, and welcome to today's event that will showcase promising practices to support retention of the health workforce in northern, rural, and remote communities. Please note that this session is being recorded. I'm Colleen Ferris, and I'm pleased to be your host on behalf of Healthcare Excellence Canada today. I'd like to acknowledge that I'm calling in from Ottawa, which is the traditional and unceded territory of the Algonquin Nation. I recognize and deeply appreciate their historic connection to this place and the opportunity to gather here today. As I turn it over to my co-host Randy to introduce himself, I encourage you all to introduce yourselves in the chat. Randy, over to you.
Sorry, thanks, Colleen. Had a little trouble with my mute button was sticking. So greetings to everybody from the heart of Treaty 1 territory and the homeland of the Red River Métis. I'm really pleased to be co-hosting this event, representing the Canadian Institute for Health Information. We've got an excellent session planned for you, including time for questions and discussion after the presentations. But first, back to Colleen for some logistics.
Thanks, Randy. A few logistical items. And we'll go to the next slide. We are pleased to offer French simultaneous interpretation for this session. If you wish to hear the voice of the interpreter, please select French from the interpretation menu at the bottom of your screen. We invite you to share your questions and comments at any point using our chat box in either English or French. And we encourage all of you to respond to comments and answer questions in the chat as you wish as we go along. If you need support at any time during this webinar, you can reach out to one of our producers using the chat feature. We'll now go to the next slide to talk about the agenda for today. So here's the agenda for today. We will start by sharing some context on the pressing need to support retention of the health workforce in northern, rural, and remote communities in Canada. Then we will have healthcare leaders from 4 sites share information about promising practices that support retention of the healthcare workforce in the northern, remote, and rural communities in which they live and work. A note that you can also find summaries of these promising practices on HEC's website. We will pop the link in the chat now, and you can also find the link in the invitation to today's webinar. As part of the final discussion segment of the webinar, we will ask you to answer some questions to share your comments. Participation in the polling is optional, of course, and feel free to share ideas in the chat instead. We'll now switch to the next slide. And before we move to hearing the presentations from the leads of the promising practices, some context on the focus of retention for today's webinar. We know that to address a health workforce situation requires actions in many areas, from education, recruitment, scopes of practice to other items. However, for this, we have focused on retention of the current workforce, especially as we know many healthcare professionals are leaving the workforce or have feelings of stress and/or burnout. Randy, over to you to share some additional context for today's event.
Absolutely. And to the next slide, please. We want to just talk a bit about the populations of northern, rural, and remote communities. So many may know that Canada's population has been slowly becoming more urban for many decades, but almost 18% of Canadians currently live in rural communities, and many of them live with more health challenges than their urban counterparts. So ensuring equitable access to safe, quality healthcare is critical. But simply offering a scaled-down version of what works well in urban areas often doesn't work well or at all in rural, remote, or northern areas. Recognizing the unique characteristics of each area is key to planning and delivering health services that truly match local needs. There's not just one rural solution. Next slide, please. Now, providing the full range of services in this full range of settings means facing a number of unique challenges, including regularly revising service offerings to ensure they're keeping up with the ever-changing needs of the people served. And while HHR challenges in big cities are a real issue these days, most rural providers are facing even larger problems. And remember, they had lower numbers to start with. As a result, rural health systems are forced to get creative in exploring new ways of leveraging the skills of the staff they have, even if that means doing some things differently today than yesterday. Virtual care options can provide an extremely flexible and convenient solution for some issues, but we all know that many health services require physical examination and intervention. So virtual options are great to have, but can't cover the full spectrum. On to slide 7. So without further delay, I'm pleased to introduce our first speakers for today. A reminder to share your questions or comments during the presentations in the chat box, and we'll try to address them at the end of the presentations. So first up, we have two presenters with Island Health Authority in British Columbia, Max Yuschuk and Dean Wilson. Max is the Executive Director of Operations and Strategy for Community Hospitals and Rural Remote Care. And Dean Wilson is the Manager of Indigenous Health for the Mount Waddington area. Max and Dean, it's over to you.
Excellent. Thank you, Randy. So I'm Max Yuschuk, and it is my pleasure to be co-presenting with Dean Wilson. We believe that we have a real exciting and innovative model that we want to be able to share in terms of retention. So we're going to be co-presenting the next few slides.
Tansi and Gelikasla, Nugo Kagikansi to CWD to Pupatin Kalas to Hukwa Mitla Lagidis Castle Bakbak Molanuksiwe. I also want to acknowledge that we're calling in from the traditional and contemporary unceded territory of the Comox Nation in the Comox Valley on Vancouver Island. And we're pleased to be able to share this information today. I do have a bit of a cold, so I hope I'm coming through okay right now, and I apologize if that's a problem. We can go to the next slide.
Okay, so Island Health is one of 5 regional health authorities within the province of British Columbia. There are 7 health authorities in British Columbia overall. There's 5 regional, there's the Provincial Health Services Authority, and the First Nations Health Authority as well. Within Island Health, we serve about 900,000 individuals within our geography, and our geography makes up approximately 56,000 square kilometers, with the majority of the areas we have responsibility for being those that are within rural and remote locations. This includes Vancouver Island, the Gulf and Discovery Islands, and also a large geography on the mainland on the west coast of British Columbia. We deliver all types of services and care for individuals on the island and visitors across the entire lifespan, including public health, child and youth care, seniors care, wellness, long-term care, community care, primary care, and hospital-based care. We make up 2,900 medical staff and over 27,000 employees as part of Island Health.
The North Island area that we are specifically speaking about with our triad governance model also serves 9 Indigenous communities, 5 of which are only accessible by air or water, as well as 2 urban agencies, the Sacred Wolf Friendship Center that supports folks living away from their home communities, and the North Island Métis Association, a local of the Métis Nation, British Columbia. Approximately a third of our population at any given time identifies as Indigenous according to the census. Next slide, please. There's been a long understood experience in the North Island that the role racism has played in accessing healthcare has been problematic, and also problematic for Indigenous staff working within the health authority or seeking to work within the health authority. There have been long held discussions for years about how to address this. And it was made clear that the only way we were going to make meaningful progress on this issue was to address some of the power imbalances that exist. So previously, the nations were in a position of working with Island Health as partners only and submitting ideas, and Island Health was in a process of continually weighing those out against other needs that exist within the agency. So the triad model seeks to shift that power imbalance and strongly situate an Indigenous lens and solution-focused approach within the governance model specifically. It's very much based on building relationships with the nations, having credibility, addressing those issues, and changing the ability to provide services. Next slide, please. So the triad model builds on the dyad model that was already in place with a medical and operational lead, and also situates an Indigenous health lead. I came to Island Health to fill that role at the request of some of the nation partners. Previously, I worked for the Gwasala Nakwakok Nation in Port Hardy, and was encouraged to take on this role, which I'm happy to have been able to do. This role has allowed us to not just have an Indigenous approach or department, but to firmly situate Indigenous ideas, perspectives, values, and cultural safety within our governance model, and allow us to consider at every aspect of our operational and medical service delivery. How are we providing good services? How are we supporting the staff that we have to do the best work that they can to best meet the needs of a community that has at times felt disaffected, and to support those staff who identify as Indigenous as well. So this has been implemented in our Mount Waddington area, and we are now in the process in different stages of shifting that to some of our other geographies within the Vancouver Island Health Authority. So some of the things that we've seen right off the bat, we've built on existing relationships. So in my case, I worked for 30+ years in the North Island, specifically with Indigenous communities, and brought that expertise to the role, allowing us to build on those relationships and create new tables and new ways of working together with the nations, and also creating systemic improvements within the system. So we've created some new ways of working. We have a new Indigenous Services Cultural Safety Committee. We're now working specifically with nations around MOUs to create an integrated service delivery system that was missing before, with the federally funded FNHA services versus the provincially funded health authority services. We've been able to look at adverse situations that have happened, create recommendations and partnerships with the families and nations that have been impacted by those, to push forward on new education systems, new processes for delivering services. We now have active engagement with all the nations in our area, both on and off reserve. They have free access to be able to contact any member of our collaborative team. It is not just relegated to my position. Everybody has begun developing these kinds of relationships with the nations, with the families that are in need. Excuse me. And we've built on further work that's preventative in nature by building partnerships with work the nations have been doing and working on that seamless system. Things like our mental health substance use team, our integrated case management team, joint funding for sobering and assessment beds, as well as the managed alcohol program run by one of the nations. We have increased engagement with the communities and outreach physician and nursing services going into those communities and working with their existing health service teams. This has been some of the big work that's come out of this type of an approach. Excuse me. Next slide. So we know we've been doing innovative work. We know we've been working on shifting the power balance to create more equity and highlight Indigenous issues within an area with a high Indigenous population. But we're also hearing back from folks about what this has meant. Previously, there was a long history of folks raising concerns within the Indigenous community, but not actually raising them with the health authority. So it seems a little counterintuitive, but the growth of concerns being reported is also an indicator that things are getting better, because people have some trust that the system is listening and willing to make changes. And we're hearing specifically from staff in this regard. We don't have approaches for reporting systemic racism within the system. So folks are now coming forward to talk about things that they've seen or witnessed in a way they've never done before, because now they're expressing they feel and they're seeing that those matters are being addressed. All of the Indigenous staff are also reaching out and feeling supported. Many have, just like everyone else, felt a little burnt out from COVID, from the ongoing stress of providing healthcare services with such shortages. But folks are reporting that they want to stay close to home. They want to continue to serve the communities. We're also hearing from staff regarding some of the new training that we're putting in place as well, that regular staff feel better equipped to work with Indigenous communities, particularly around mental health and substance use issues, and a more trauma-informed approach, and feel much more confident about the work that they're doing. And they're telling us that. We're also hearing from the nations that they feel supported, that they feel that the service delivery structures is improving, that the relationships are getting better, and that we are all working together at the same time. So increasing service delivery systems, increasing cultural safety, and supporting staff to provide the best services they can under those circumstances is really key to the approach that we've been putting together here. Next slide.
All right, I'll jump in, save Dean his voice. So very excited about the progress that we're making in identifying and looking for opportunities to address systemic and actual racism within the system through this model. Next steps are to be able to academically evaluate the model and be able to spread those learnings across our organization and other organizations and health authorities across the country and internationally. Thank you very much.
Fantastic. Thank you so much, Max and Dean. Great to see a tag team getting this started, showing the partnership and modeling the things we want to do elsewhere. Next up, we're going to go up to Northern Manitoba, and our speaker is Jason Kleinchar, who is the Executive Director of the Churchill Health Center. Jason, it's over to you.
Thank you. So I'm actually coming to you from the Churchill Health Center. I'm on Treaty 5 territory, the traditional lands of the Inuit, Dene, and Cree people, and part of the Métis homeland. So I'm kind of mentioning this in the spirit of reconciliation, but I think you're going to see as part of this presentation how we've taken those steps towards that reconciliation, not only as me as a leader, but as an organization in general. So just a little bit of background on Churchill. We're located in northern Manitoba, right on the shores of the Hudson's Bay. So where I'm sitting right now in our executive boardroom, I could, on a good day with a little bit of wind, probably toss a football into the ocean from here. So when I say on the banks, we're literally on the beach here. So we have about 120 staff that work here, between having an emergency room, an operating room, an acute care, as well as long-term care beds, and a primary care clinic. So our main community served is Churchill. There's about 850 people in our community, with 65% being Indigenous. Now, we do also supplement for communities outside of Churchill, specifically Indigenous communities in our Brochet, Lac Brochet, and Tuduli Lake, just to help manage some of their day-to-day healthcare, specifically around physicians coming from Churchill. So the only way you can get into Churchill is why we're classified as rural remote is there's only rail or air available. There's no way to drive into Churchill, as well as the outlying communities around us. One of the main draws of our community is in the world actually is tourism. We do have the title of polar bear capital of the world. Most of you may know in Manitoba, obviously, that polar bears just walk through our town. So although there's 850 people in our community, during tourist season, usually that starts in July, we usually see a bit of a doubling of that population. So we'll go to the next slide. So I think there's a few things that I'm really going to focus on here, specifically around our nurse recruitment. Now, I would say that I've been here for 5 years. I came up, I am a nurse too by background. I've been a nurse for about 20 years. I came up 5 years ago for a couple of weeks and I never left. So this is my forever home. It took me 20 years to find out, you know, what I want to do with my career. So this is it. And I noticed something really kind of the start of this. And I think it was really simple. And it's about creating that meaningful work-life balance with the staff. But all we started doing, you know, again, 5 years ago, was just smiling and saying hi, good morning, good afternoon to staff. And I know some of your organizations likely do something like that, but how quickly that changed things within the facility, that we got to a point where community members are saying, your staff seems really happy. They say hi to me every day I walk through the facility. That was just this first step towards something. Now, we had some operational pieces that were already available to us. Specifically, the nurses work a 12-hour schedule. Now it's 4 on and 4 off on this day-night rotation. Without getting into the really complexities of it, that actually allows, because nurses work 7.7 hours in general, that actually allows us to provide 2 times a year where they're given a 4-day, 12-hour rotation off, which that means they get 12 days off in a row. So when you're in these rural, remote communities, with round trip airfare to Winnipeg being about $2,000, obviously the fact that we're able to provide that kind of extra vacation, most nurses kind of tack on some vacation to the beginning of the end and end up having about 3 or 4 weeks off, which is significant when you're in this really remote community. So it gives them opportunity to come and go a little bit, and it gives them a means of traveling to go visit family or friends that are outside of Churchill. So the culturally safe work environment, I mean, I'm going to say that some of this naturally happens with our community, because we do have a high population of Indigenous people within our community. But another real big piece of this is actually we really focused on promoting from within the organization. So our leadership team is made up of mostly community members that have started in different entry-level positions within the community and have either built up through experience and or education to move into different types of leadership roles. So we always try to pull within the organization first to build up that institutional and community knowledge. So that's another way that the staff started feeling a little bit more, I would say, like family. And then obviously we have a couple other operational pieces. We have the subsidized housing that was a significant piece of the success here. We do have a housing unit for all of our staff that's literally across the street. It's 182 steps from my office door to my home door. So that's probably closer than some of the leaders on the call here from their office to the unit. So, that definitely is a really big plus. So everybody's in the kind of the same building. You get that sense of community, not only at work, but after work. And we kind of have a wing of that building that's all the toddlers and all the kids, and we kind of have a wing that's maybe more of the younger crowd that like to stay up late. So we have this community that we've actually built outside of the workforce in the health center. Another big thing, we have no contract. None of our nurses have signed a contract to stay in Churchill. They stay here because they want to stay in Churchill, and I think that's a big piece of this too. There's nothing keeping anybody here if they don't want to be here. These nurses truly want to be here. And then the childcare services is another very unique piece to Churchill. I believe we're the only ones in our province where the childcare employees are actually employees of the Churchill Health Center. So we run the daycare and actually leverage that through a lot of our programming within the community as well as the health center. So it also creates a little bit of an easy access to childcare for our employees, as it's literally right in the health center. It's steps from where I'm sitting right now. So all the employees that work within the health center actually, they have lunch with their kids at the cafeteria or etc. It just creates this bigger family dynamic. So if we go to the next slide. So I really wanted to put this out to everybody because I don't know what the stat looks like. And I really believe that this is, I think, an indicator that we can all use. So we have not had a full-time nurse leave our facility since June 10th, 2020. So we are pushing 3 years of having the same nursing workforce in our facility, which I don't know how that compares across. I'm pretty sure it's pretty good in our province, but I don't know how that compares federally. But I think that this is a bit of a number that we could massage as a group and kind of use this as a bit of an indicator as what we could, how well are we actually doing? Like, is this good? I don't know. Other places are saying, yeah, Jason, we've had the same unit nurses for a decade. I'm not sure what this actually looks like in a rural remote area. So I'm throwing this out for everybody to say that I think this is how that we could actually use this as a metric going forward. So go to the next slide. So I can narrow it down to these kind of 4 thingies. Success breeds success. I told you the first thing we did was smile and wave at people. And then all of a sudden, everyone just got happier. And, I'm saying this as a HR perspective, but there's obviously a lot of programming perspective that comes into this success. And I could say, just again, from a perspective of a rural remote leader, that I would say one of the biggest overall outcomes of this is our perspective, my perspective, the leadership's perspective, and the perspective of every single nurse and employee in this hospital is that we do not have a hospital with 29 beds. We actually have a community with 850 beds. So we're able to kind of, blur the lines. So nurses are not just looking at the discharge out of the hospital. They're now looking at the further ongoing, how else are we supporting these people within the community? So that's how I would say success breeds success, and nurses get to see, the fruits of their labor very quickly. We have a very engaged leadership. Again, that was the breeding from within too. Our leadership has been, the same group has been together for about 4 years now. So we're able to obviously push a lot of stuff forward. And that's the other benefit of having leaders from within the community that live in the community, born and raised in the community. We have them now. So we're not constantly, changing our leadership team as people come and go. I mentioned the strong involvement in the community, and I don't even mean, outside of work hours. There's many other committees and boards I sit on as a leader, and that's what the community wants. They want to see me out there, not just as a hospital leader, but as a leader out in the community. And they also see our nurses like that too. Many of our nurses volunteer for different events that they're just enjoy doing. So it kind of creates a bigger leadership perspective of the whole health center. And I just threw this in at the end. The addition of the scheduling clerk during business hours. We just brought a scheduling clerk in literally like 6 months ago to do all of the scheduling, not just the 24-hour schedule, but the Monday to Friday schedules. And that has been a big benefit. So I would say that just building from within and getting rid of some of those ideas that nurses have to do and putting them to other people has been a success too. So I think that's my last slide. If we can go to the next one there. Yes, simple for going forward. Still about training from within the health center, bringing education to the community. So that's what I got.
Awesome. Thanks so much, Jason. That's a great presentation. It's really good to see the difference that focus on local training and mentoring can make in a small remote community of polar bears and beluga whales. Oh, sorry. Right. A community that includes polar bears and belugas.
That's right.
Up next, we're going to come a little bit south in Manitoba, and Melanie McKinnon is going to speak to us. Melanie is the Executive Director of Ngomazwin Health Services, based at the University of Manitoba. Melanie, it's over to you.
Thank you, Randy. I'm not sure if I'm seeing a different kind of screen here.
We can hear you well, Melanie, so please just proceed, and hopefully we'll get the video to line up with you.
Okay, great. Good afternoon and good morning, everybody. Happy to be here with you all today. I'd like to talk to you about our experience on Ngomazwin around permanent part-time physicians. And so maybe we can go to the next slide. So prior to 2017, Ngomazwin Health Services was known as the Northern Medical Unit. And prior to the pandemic, we were very, very fortunate to celebrate our 50th anniversary. I often joke that we're almost as old as Medicare within the country. The picture on the left there is our founding physician, Dr. Jack Hildes. And I'm proud to also state that his daughter continues to be one of our pediatricians and on our team. We currently provide physician services, med rehab services, and physician assistant services, specialist physician services, and nurse specialist physician services into 26 out of 63 First Nation communities, and specialists and med rehab specialists into 8 hamlets in the Kavalik region of Nunavut. What I'm going to talk about here today is specifically around family physicians. We currently have around 70 family physicians on our roster and 70 specialist physicians on our roster as well, to a maximum of about 200 clinical positions, as previously mentioned. Next slide, please. So in 2010, when I started at the university, we had a pretty significant problem with respect to physician retention. At that time, our vacancy rate was on average 50 to 60%. And in some of our practice environments, it was upwards of 70 to 80, specifically in our hospital environments. So we operate or we provide physician services to 3 hospitals within the province, one being Churchill. Thanks, Jason, for the presentation at Norrie House Cree Nation, as well as Hodson Hospital near Peguas First Nation. And our vacancy rate was quite substantive. There was an expectation at that time that physicians had to live in the community or they had to reside there full time. We worked with our partners and our physician group and our and Docs Manitoba to look at a different employment model whereby we could recognize as low as a 0.25 full-time equivalent as a permanent position. At that time, we weren't doing that. So many of our hospitals were actually staffed with locums who were, available on average one week a month. And so, we knew people wanted to work in our practice environments, but they couldn't live and work there full time. So what could we do differently? And we were able to get funding from our federal partners to be able to accommodate the extra travel, specifically in those 3 communities. In the other communities, we did have money for physicians to travel on a weekly basis. Next slide, please. There are many key components to making this model successful. We wanted to be an organization that was reflective of the communities that we served. So Indigenous leadership was very, very important. I'm a First Nation nurse, originally from Misspellowship Cree Nation, and have over 25 years of healthcare administration as well. We wanted to ensure that we were recruiting the right physicians and the right fit to serve our communities, and that included the medical students as well. We require our medical students to offer a letter of interest in why they want to have this experiential learning experience. And we also require all of our physicians to sign a physician charter that is reflective of the communities we serve and their traditional teachings, specifically First Nations. And we also see that the clients that are primarily First Nation, Métis, and Inuit that we serve, we see them more than their health status and more than their psychosocial needs, and see that we do have a broader responsibility with respect to social determinants of health. And we realize that through our vision. Next slide, please. Some continued success factors also include our opportunities or abilities to have, again, those training opportunities that are also interdisciplinary. And we do host and accommodate many students throughout the year in our practice environments. And we also spend a significant amount of time with our physicians and physician engagement and leadership. So we meet with our physician leads on a monthly basis and clinical leadership groups. And we also have an in-person annual general meeting with all of our physicians and our specialists in January. Next slide, please. So how do we know what we're doing is going well? Well, we went from a 50 to 60% retention or vacancy rate to an overall average of 20%. And in our 3 hospital sites where we had the most significant challenges, we have a vacancy rate of 0 to 5%. And that has been consistent over the last 6 years. So overall, our retention rates have improved from 6 months to 6 years. And I like this quote from one of our physicians who shares that I couldn't relocate my family to a remote community. Being able to work 1 week a month allows me to balance my personal and professional priorities as an OHS physician. Next slide, please. Just a couple more slides to go. And so overall, these key success factors have allowed for an engaged, supported, and dedicated physician community of practice. Again, with that secured funding for travel and logistical coordination has really helped to operationalize the program. We absolutely have culturally and clinically competent practitioners. By them practicing part-time in a larger center, whether it's Emerge or ICU or an addictions unit or harm reduction program, they bring those clinical competencies into the remote and northern practice environment as well. And so their clinical competencies are exemplary. Communities have consistent clinicians and options for provider of choice. You might have a community that has 2 visiting physicians on an alternate basis, and a client can choose what doctor they want to make appointments with on what week. And we continue to have or key investment in upfront provider travel costs prevents the downstream exponential costs of transporting patients. And so that has been significant as far as a success factor. We continue to do this work around supporting our family physicians, but also expanding that program and working with newer communities in the last number of years. And we continue to look at expanding our specialist services to also have an equity lens on the communities that we serve. And so maybe I'll stop there, given time, and that this is also available in the summary. So thank you very much for the opportunity.
Fantastic. Thank you, Melanie. Really good job running through that for us. And congratulations on the results you've already achieved. You know, it's one of those things that the solution seems deceptively simple in principle, but I'm sure it required a lot of intricate planning and coordination by you and your team. So congratulations on that. Great work. Our next speaker is Robert McMurdy. Robert is a nurse practitioner consultant with the Department of Health in Nunavut. Robert, the virtual floor is yours, which I think is quite appropriate.
Perfect. Thank you so much. Yeah, as mentioned, so I'm here just to present on behalf of the government of Nunavut about our virtual triage program, which is an approach to support retention for on-call community health nurses. Next slide, please. So just to start off just a little bit about Nunavut. So there's approximately 38,000 people living across 25 communities. Nunavut accounts for 1/5 of Canada's land mass. And all communities, which is really important to know, is remote and only accessible by air. Approximately 84% of the population is Inuit. And other than Iqaluit, so there are 24 Nunavut communities that are supported by health centers. And it's these health centers where nurses are responsible for maintaining access to care by on-call services. Next slide, please. So just a little bit about the role of the community health nurse and why it's important to provide them respite. So we often refer to them as CHINs, and they're essentially registered nurses who work in an expanded scope, and they're responsible for providing on-call services to maintain the 24/7 access to care. So all call shifts, they can be up towards of 24 hours long, so quite long over the weekends. And if you have a busier night with phone calls throughout the night or seeing multiple patients, it can quickly disrupt sleep and become exhausting. A second point just to note as well is during times of staffing shortages, the frequency of having a CHIN in the on-call rotation also increases, which can further lead to burnout and exhaustion. Next slide, please. So a little bit about the program in itself. So the virtual triage program was initially designed to provide respite for these CHINs. So initially we developed a successful pilot study that was 3 months long, and we looked at various communities and a significant number of shifts. So what we found is that majority of the calls could actually be successfully managed by the virtual triage program and did not necessarily need to wake up and activate that nurse on call in the health center. So given this and the success that we had, we got the green light to turn this pilot project into a sustainable program to support our frontline staff. Next slide, please. So a bit of about the program in itself. So the virtual triage program is generally available to any one of those 24 community health centers and typically used when we're facing nursing shortages, or if that community is seeing an increase in patient volume and acuity where they just need further support. So the supervisor of the health center would typically just request the support to be used for a certain period of time, then we would provide it. So the virtual CHINs and NPs that are working in the program typically can cover about 2 to 3 communities per night and receive on average about 10 to 15 calls. So during a pilot study that we had, so out of these 10 to 15 calls that they're receiving per night, an average of 73% of them actually did not need to require us to wake up and activate the nurse on call in the community, which is a pretty significant statistic that we found. So all incoming calls that are after regular clinic hours are typically triaged and filtered by the triage program. And then we assess the need for whether a client needs to be seen or not. And our criteria that we're using is based on CTAS scores of 1 to 3, which is your higher acuity patients, And anyone that falls under the GN or government Nunavut's must-see criteria, which is our high-risk patients. So typically we're deferring any calls by providing clinical advice, calls around medical travel or appointments, or someone calling in with a low acuity clinical concern, or often wrong numbers. And a really important point to note about Nunavut with respect to this is in the summertime, we can have some communities have months of straight 24 hours of sunlight. And this often disrupts people's circadian rhythms, and people are on reverse sleep cycles. So oftentimes when you wouldn't think that you would receive calls throughout the night, they tend to increase because of this as well. So which highlights the importance of the program. So just to provide a bit of evaluation that we did, we compared a head-to-head study looking at one of our communities and wanted to know what was the impact of using the program and the impact of the typical way of them triaging. So what we found is that for about a month period, when we were introducing the program and having them support the community, 40% of all calls received required us to activate the nurse to see a patient. So 60% of the calls were deferred up until the morning. Whereas when we didn't use the program and compared to the traditional way that they're triaging, 73% of all phone calls led to the activation of that nurse going to see the client in the health center after hours. So it's a significant difference that we did see. Next slide, please. So the main question, how do we know that this program is improving retention, and how does staff feel about it? So we just completed a 12-month of our annual evaluation on the study, and we surveyed many of our staff, and just to highlight a couple of them in particular of the results, but there's more that are available in the report on the HAC website. But staff are reporting less burnout, higher work satisfaction, and generally feeling supported. So on just a quick statistic, so 92% of on-call nurses felt that this is an important service to continue in order to support and retain frontline nurses. And just to share a quick statistic or a quote from one of the nurses. So this service provided very appropriate triaging and avoided bringing in unnecessary patients that could wait until the morning or the next day. I feel this is an amazing service to continue to provide to decrease stress and nursing burnout. Next slide, please. So some key success factors just that made this program successful. So the Department of Health and promoting innovative projects, and they really supported this for us to be able to turn in and materialize our vision into a sustainable program. High quality virtual triage CHINs and NPs, which ultimately led to high quality triaging and ultimately not having to wake up the nurse on call in the community. And certainly to stress that our dedicated project managers are working around the clock and oftentimes after hours to meet the demands of this program, and also providing last minute requests. So our flexible IT support that we had to also provide last minute requests, and our eHealth department, who continues to work with us to provide quality improvements in the program. And lastly, the support from our community health nurses, which it's their desire to keep this program alive and demand for it that continues to ramp up efforts. And just to provide a little bit of background, so from May 1st to November 23rd last year, so we supported in total about 547 triage shifts, and this number continues to increase, where we're supporting about anywhere from 6 to 12 communities per day at once right now. Next slide, please. So next steps, ongoing evaluation. So what we're hoping to now learn is what is the cost comparison of using this program compared to the cost savings of now diverting all these phone calls and diverting patients that don't need to be seen after hours to the next day. So from our initial impression, we actually feel that this is breaking even. And there's not an increased cost that we're having, but hoping to gather some concrete evaluation data on this. So other things that we've introduced is we've introduced this virtual triage program 24/7 in communities that are under critical staffing shortages, where we have to temporarily suspend health services in some of the communities where there's no nurses. And also we've now introduced paramedics in the on-call rotation, because we can have them be supported by the virtual triage nurse. And obviously, we're going to continue to engage with our frontline nurses and leadership to further identify other ways that we can support them and modify this program. Next slide, please. And so that's it for there. So just for acknowledgements, I really wanted to just highlight, give a shout out to our program managers who have just been so passionate about making this program successful, and it certainly shows with all their diligence and hard work. If anyone has any questions, feel free to please email me, and there's further information that in the report that's on the HEC website. I certainly feel that this is transferable to many jurisdictions working in or that support rural and remote communities. Thank you very much.
Thank you, Robert. Just a moment of thanks before we open it up and start addressing some of the questions in the chat, and I know more are coming. So it's really good to hear about that one, Robert. It's clearly making a difference, and probably there's some room to expand. I can say a bit because I too have the great privilege of working with Nunavut and have been in territory a number of times. And so this kind of thing can make a real difference in those remote communities. You'd mentioned earlier, but I'm just going to restate it for those who might not have caught it, that the many residents of Nunavut live in 25 isolated communities. That is, no two of them are connected by road. So the virtual services there are a brilliant way to complement the local capacity and really add an ability to deal with things. So I'm going to start working through some of the questions that are in the chat, and people can keep them going. Understand we're not going to get to all of them, but we're working through. So the first one I'm going to send just a general answer to a couple of people that asked about, the definition of rural versus urban, and an answer to that went into the chat. I'll just say that, there's a variety of definitions, and of course, in different contexts, different things seem appropriate, but there's a variety of things around. If you look that up in the literature, there's even a couple of good review articles that you can find on that. Jason, I'm going to come to you now. There was a couple of questions about the work you're doing in the Churchill Health Center, about whether that 4 and 4 shift constitutes a full-time position. Why don't we start with that one?
Yeah, I noticed a couple questions about that one. So yes, that is a full-time position. And without getting through like the technical weeds on it, that would, like, I could share the rotation, I could share the collective agreements. This is all public knowledge, or I could even do a little bit of a bigger conversation for those who are interested in it. But that is full-time work. And when they do take that 4 days off twice a year, it is technically unpaid, but most of the nurses will either use their stat time, overtime, or whatever to pay off those days. So it ends up being still a full-time kind of paycheck. Problem with this rotation, without getting into it, it's a 6-week rotation on an 8-week schedule. So it's complicated, but if anyone's interested, I can share it with them for sure.
Sounds like that staffing is a bit of a Tetris piece of work. So good
Absolutely.
for you, Jason. Thanks for that. And I'll just note that you'd said the 4 days off, but I think you meant the 12-day off stretch.
Sorry,
right?
yes, the 12 days, 4 days off the rotation. Yeah.
That's all good. Well, when I heard they were 12-hour shifts, I thought, okay, surely 4 of them in a week is a full-time job, because that's 48 hours of coverage right there.
That's right. Yeah.
Awesome. I'm going to send the question now to Melanie about the Ungamiswan example. So the question is whether all the permanent part-time positions that you've got, are they all from Manitoba or from other jurisdictions as well?
Thank you for the question. We have positions from multiple jurisdictions with the Manitoba license, of course. So I would say about half of our positions are from BC, Alberta, and certainly quite a few from Ontario. Those that are working in the hospital-based program, we ask or require them to have a 10 to 14-day commitment. So they often will come in on a Monday morning. They'll stay over the weekend and be one of 2 physicians on call in the hospital-based programs. And then they will work the second week and their shift on a Friday and go home, and we pay for their, and in doing so, we pay for both legs of travel from their base province, our home province, and then from Winnipeg up to the community.
Awesome. Thanks, Melanie. Great answer for that one. Robert, we've got a question for you now, and it's about whether the community health nurses use the same criteria as the virtual on-call people, and if so, why the difference in the attendance patterns?
Yeah, so they do use the exact same criteria, and it would be following within the same training guidelines as well. It's a really good question, to be honest, and there's a number of probably multifactorial reasons for that. Oftentimes because we have someone dedicated outside the territory, they're able to spend a significant amount of time actually talking with the patient and whatnot as well. Whereas, in there up all night. Whereas if you're already pretty exhausted, a nurse in territory, and it's maybe 4 a.m, you might just decide to just go see them, and it's easier that way, right? We haven't really looked into that too much, but I think there's multifactorial reasons for that cause, though.
Yeah, almost always, eh? There's no one simple answer to it. Thanks, Robert. That's really great. I'm just going to make a few notes that Kelly Ripley from Healthcare Excellence Canada has kindly put into the chat a couple of links that you should all know about, because there's a variety of things available on their website and some other things on CIHI's website as well. So this chat will be available to you, and you can click on those links, and it'll be easy to find afterwards as well. Both of our websites are pretty easy to hook up. Jason, I'm going to throw one more question your way. Somebody asked about the amazing childcare services provided at the Churchill Health Center, and are those sort of 8 to 4-ish, or is it 24-hour available? How does that work?
Yeah, that is an 8 to 4. So the building that the hospital in is the same building that the school is into. So there's a bit of an after-school program. So it is 8 hours technically, but we're trying to kind of extend it a bit, but we're not having the need for it right now. The best I could say is that if your kid needs a daycare spot, because we just bring in more daycare workers as we have kids, we've never had put anybody on a true waiting list where they couldn't start work. So yeah.
Wow, no wait list for childcare. Don't advertise that too.
Yeah, good. Come up with Churchill, yeah.
Yeah, that'll be a very popular thing. I noticed a couple other questions coming in. One from a veterinarian saying that, a lot of the challenges they're facing are similar to those we're dealing with in human health. So I suppose not surprising, but thanks for that comment. And another note there's just gone into the chat that a recording of this session will be available in the days to come. So hopefully you'll be able to use that if you want to revisit it. And more importantly, share it with colleagues and people that you know who you think might be interested, but that weren't available to be able to join us today, because we know that scheduling never allows everybody to be there at a single time. So that's really good. The other thing that's on that Healthcare Excellence website is for each of these 4 stories that you've heard of today, there's 4 more, but there's also quite a bit more detail in those write-ups where you can get a fuller description of what's going on. I believe there's also contact information for the people involved, and if not, you can get a hold of us either at HEC or at CIHI, and we can make sure that we connect you with people if they want to do particular follow-up. So I'm just scanning the questions here. There's another one here from Jennifer White. What training or professional qualifications or designation do the triage intake staff have? I think that's to Robert.
Yeah, so we have what we mandated that they would require for training is CTAS training, which is the Canadian Triage Acuity Score. So that triaging is typically designed in person, but we kind of modified it in a way that we have the person who's teaching us, they are familiar with virtual triage as well. So they added in elements within that, which was important. And we also required that they have to have in-territory experience as well. There's a lot of nuances and there's a lot of really important information and training that they would need to know just with the Inuit and how to navigate healthcare as well up here and provide appropriate advice over the phone. So.
Yeah, the context is so different in Nunavut communities, eh? That's really, I didn't know that they had that experience. So that's a really great thing to be able to draw on, because that's not commonly found in people from the rest of Canada, that sort of local knowledge to know the context and what options might or might not be available.
Absolutely.
Awesome stuff. I got a question that's just come in for Max and Dean. Curious to know, this is from Marie-Eve Barbeau. Curious to know, what were the first steps to train staff about cultural safety, what content was provided first, and the impact on professional achievement? Max and Dean, if you can come back online, we'd love to hear your thoughts on that.
Thanks very much. Our Island Health Indigenous Health Department has a cultural safety learning journey that's already in place. It begins with the Sanyas course, which is available to all public service folks in British Columbia. And we built on that in partnership with the nations on the island to create a more enhanced view of what trauma-informed practice and cultural safety practice actually looks like above and beyond the foundational information. Locally, we've also been developing increased training in communities of practice. And we're moving into a pilot project with our ILN, our Indigenous liaison nurse, who's now working for cultural safety in creating a cultural safety learning journey for leadership, because hitting leaders is really critical in being able to translate this down to the local ground frontline level. So those have kind of been the focuses of where we're at right now.
Fantastic. Thanks so much, Dean. All right, Colleen, I think you're going to take us into the next step with some polling and a wrap up.
Thanks so much, Randy, and what an inspiring to hear the stories, knowing it's such a challenging time for the workforce, but knowing that there are these promising practices certainly gives a lot of hope of what's going on there. So as we look to, as we close, finally, your feedback is invaluable for us for future session design. So we ask that you please take a moment now to provide us with some feedback on today's session. And we are going to start a poll, and the poll questions are, and you'll see it pop up there on your screen. It is, what is your gender? Is the first question. Gender refers to the gender that a person internally feels and or the gender a person publicly expresses. The options are man, woman, gender diverse, prefer not to disclose. That's the first question. And then the second question is, did your knowledge about promising practices that support retention of the healthcare workforce in northern, rural, and remote communities improve as a result of participating in today's webinar? And the selections there are yes and no. And the final question, do you feel the webinar provided useful information? And those options are yes and no. And please be sure to submit, hit submit to share your responses with us. So we'll give a moment or two more for that before we end the poll. And as we're waiting for that to highlight, as Randy mentioned, there's also 4 other promising practices as part of this work that CIHI and HEC have done, and we will be coming out with another webinar in the near future to share those promising practices as well with all of you.
Yeah, thanks, Colleen. I just want to give one more shout out to everybody who's joined us today. It was fabulous to see such a great turnout, the engagement through the chat. The questions were smart and on point, and lots of interesting interchange between members. So thank you everybody for participating, and please share the word. The recording will be available soon.
Absolutely. Thanks so much, Randy. And thanks to you and our partnership with CIHI, and a really special thanks to Max, Dean, Jason, Melanie, and Robert for their informative and encouraging presentations today of the work being done to retention and support of the current workforce that ultimately supports patient care. If you have questions or comments following today's event, please contact Jennifer Major using the email address that we will show on the screen. And of course, thanks to all of you, our audience, for joining us today. This does conclude today's event, and we wish everyone a great rest of your day. Thank you.